It is a huge honor today to be interviewing Ken Serota, who was the first endodontist rock star on the internet. He was a big fan of mine. He started ROOTZX. I started Dentaltown in '98. I think ROOTZX was before Dentaltown even. What year was ROOTZX started?
It started in 1998.
So we started the same year.
Same time.
And you collected the most famous endodontists, not just from, it wasn't a United States play. You had endodontists from Russia and India. And I mean, I don't think there was a country on the map that didn't have someone showing an endodontic case on Roots. I mean, that was the single largest endodontic impact on my personal life. And I want to thank you for that, Ken Serota. I mean, you were a visionary. You were ahead of your time. And, I mean, some of those cases there, I mean, it was just amazing. So I want to so when we go to Dentaltown and we look at the 200,000 dentists who have posted 4 million times, the biggest, hottest topics are root canals, implants, and practice management. You know, am I making money, losing money, corporate dentistry, implants, and root canals? So I want to go right to the killer question. I wanted to open up with this because I thought two older guys could answer this better. I keep seeing new patients for 28 years where they went to a dentist and across the street, down the street, and the cavity got deep. So then they went to spoon excavation, then they put Dycal, and they tried all these things, and the patient went back, and it's sensitive. And finally, a month later, this patient's had a nightmare. They did in my office, and I just killed the damn pulp, do a root canal on the crown. Ken, where do these young dentists cross the line from being a good, ethical, moral dentist and trying to, you know, avoid a root canal versus, come on, this patient's 30 years old. She's going to be alive when she's 80. You really think this tooth's going to be alive for another half century when you're down there placing Dycal? So, but if you get too aggressive, then they say, oh, well, Howard, you just didn't want to do a $250 filling. You want to do a $2,500 root canal on the crown. So, Ken, my first question to you is, what's the difference between being a conservative dentist and saving the pulp versus just kill the damn thing, do a root canal, and put them out of their misery?
Well, I think you're seeing, as we're seeing in Dentaltown and Nexus, that the world is going back to a more minimalistic approach, bioemulation, this sort of thing. The most recent studies related to dealing with vital pulp therapy from people like Martin Trope and the like, and a variety of other people from around the world, are that excavation of caries should be done incrementally, in stages. It allows the pulp the capacity to regenerate in a much different way than it ever did just by barreling everything out. I think our appreciation of the impact of what air rotors do and the need to have better control, water control, heat, this, that, and the other. The advent of lasers in terms of hard and soft tissue removal is going to change a lot of things. I think the reality has hit home that even in doing root canal, there's still a 5 to 10% recidivism rate, no guarantee. So I would imagine that the vast majority of restorative dentists today are going to look to new technologies, new research, and try and change that direction. They may not commit the tooth to full-blown prosthetic sophistication, but they will certainly, in the world today, try and do less being more in the sense of incremental removal, laser usage, and even if they're forced to do root canal, for example, I think there's a whole shift. You're beginning to see a tremendous shift in what was essentially conventional root canal therapy and what is now sort of biominimalistic approach, both to access and restorative-driven endodontics. So there's a huge swing in what people are trying to do. We believe we can preserve pulps in a better way. You're seeing that in terms of even cases that apices are incomplete. The advent of regenerative endodontic procedures for teeth that haven't fully formed, rather than just committing them to root canal and surgery and this, that, and the other. There's tremendous trends emerging at this time in our day, in this day.
So talking to these general dentists specifically, like, you know, do you use caries detection, or does caries detection over detect with affected dentin versus infected dentin. And when you're talking about incrementally removal, instead of just taking a number 6, 8 round burn, blowing it all out, be more specific. Name. How do you do this? Do you recommend Caries indicator? How do you remove incrementally? What do you pulp cap with? Calcium hydroxide.
Well, you raised the issue, for example, of affected versus infected. I mean, even using a spoon excavator to peel away leathery dentin, and then using, for the time being, resin reinforced glass ionomer, knowing full well that you're going to go back in. As far as caries detection agents, I mean, absolutely. I think they're invaluable. Today, of the systems that are currently out there, the one that I would most strongly advocate based on the research is the Canary system by a local Toronto boy who's marketing it, Steve Abrams. Diagonodent and whatnot, there have been a number of them out there, but it seems that this Canary system has just sort of started to really take off, and it's got tremendous science behind it, validating its ability to detect early stage decay and whatnot. And I think you're going to see increasingly, we're never going to get the Doppler flow, that kind of thing, but I think that type of technology will continue to emerge, and Caries in its infancy or earliest stages will be picked up and will be able to negate that concern.
And for someone who's never heard of the Canary system, can you explain any more about that?
I'm not totally sure how it works. I would imagine that, again, there has to be some sort of optical capacity for measuring the changes that are occurring on some level. I don't know that I fully understand the mechanics, but I know that from a standpoint of validation, the research that's been done behind the Canary system has just been tremendous. They've received tremendous accolades from the scientific community, the research scientific community, in terms of its validity and value, in terms of achieving the end result of early detection of tooth decay.
So you've been an endodontist for decades.
About a century now, I think.
A what?
About a century, I think.
A century, you think?
Yeah.
What do you think of? What are the most common mistakes you're seeing general dentists do when you're working? You're an endodontist. You're working with general dentists. What is the low hanging fruit that someone like you? I mean, you've been doing endo for how long?
Right now, about 30-odd years, 33 years, I guess.
Okay, so 34 years, and a lot of these kids are listening to this 5 years out of school on these podcasts. What are their most common mistakes? What's the low-hanging fruit that a guy who's been doing it for 34 years could coach these kids on?
Okay. It's interesting that you mention that, because theoretically, I think the first thing that anybody who is going to do root canal therapy needs to do today is to look at the work of people like Marco Versiani, Ronald Ordinola Zapata. These are things that you can pick up off the internet. These fellows are using micro-CT to essentially show people the enormous complexity that is present in the root canal systems of every conceivable tooth type imaginable. So I think that tragically they're so used to looking at flat films and post-treatment white lines that are submitted to insurance companies that we really have lost our ability to understand the labyrinthine complexity of the root canal system. I mean, it's just simply staggering that people undertake treatment with a single X-ray or a badly angulated film or a foreshortened, elongated, or cone cut, whatever. That's where cone beam obviously is coming into it. And from my perspective, the most invaluable image in the cone beam sequencing is the axial image. And so I think from a diagnostic standpoint, if they've determined that that tooth is requiring root canal therapy, then I think quite honestly that within the next certainly 5 years, the gold standard for endodontic diagnosis has to be CBCT. There's got to be cone beam imagery taken to augment. And if you don't do that, at the very least, multiple digital films to try and gain a greater appreciation of curvature and anatomy. But they really need to understand the complexity of the root canal system above and beyond what is sort of traditional in the white line imagery that everybody associates with the quote-unquote look. The other big concern that I have is that At the moment, there are 100 NiTi systems on the market. And so you've got, where you have it, especially where you've got these sort of armies of representatives from the companies going out, you're being like literally deluged with this system works, that system works, we can go to single file, you go to reciprocation, you go to rotary. There is just a tremendous push to try and imprint single file usage onto teeth that are far more complex, that require far more consideration. A single tool can't be used to create a Michelangelo statue. Michelangelo didn't carve the David with one chisel. And I think there's a tragic shift in the marketing of endo as one file, one obturator, whatever, and then you're done. And so if there's anything that they need to understand, it's the fact that instrumentation requires a sort of not a generic or singular approach. It's an extremely sophisticated approach, dependent upon curvature, dependent upon location, position, patient access, this, that, and the other. But then the biggest problem, of course, is that most of these young folks haven't addressed the implications of things like biofilm, what people like Anel Keeshan are doing, Costerton did, what Gary Carr and people like that have been screaming about for years. The most underrated, the most undervalued aspect of endodontic therapy is the ability to irrigate well. That's why Son Endo is coming on strong. That's why PIPS has mattered. That's why everybody who practices endodontics on any level has to understand the implications of passive ultrasonic irrigation. But there's no drive for that because they're renewables that cost nothing. In most cases, it's sodium hypochlorite. So, you buy a jug of Javex or you buy something that's been modified with sodium hydroxide, and there's no money in it for companies. The tragedy is that's what does the majority of the work, provided you've given it access to eliminate and debride and disinfect the canal system properly. So from my perspective, we're being sold all the tools and all the root filling material, but we're not focusing on the thing that eliminates the primary cause of root canal disease and apical periodontitis. So I think if I were a young guy, I would want to have a better understanding of pulpal biology, apical periodontitis, all the implications of what causes pulpal disease so that I can avoid a number of things, over instrumenting a canal system, ensuring that the canal system is truly cleansed, that I've achieved the biologic imperatives, and not just because I bought a single file reciprocating system and a core-based obturator that I could retrieve if I had to. I think there has to be a balance between market and science, as there is in everything, be it implants, be it restorative dentistry, whatever it is. But I think that's the problem. When you've got 100 systems on the market and literally new ones coming out all the time, I think there's a lot of confusion at the moment.
Absolutely. So let's start off with the gold. What is the gold standard for pulp capping? Would you you would use Caries indicator? You would use a spoon excavator, and what would you place on it?
Historically, probably MTA. Even that's shifting now to bioceramics, the putties, or biodentin, which is coming out of Europe. The big push in endo has been that there's obviously a need for reevaluation of the obturation materials that we are using. And you're seeing that coming out from people like Ali Nassa, Real World Endo, Martin Trope, Debelian. Bioceramics are I wouldn't say taking over, but they're impacting significantly. And the day will come eventually when I think bioceramic root filling materials will represent the largest burden in terms of obturation equipment or materials that are required. Hasn't happened yet because the vast majority of people are still, I think the world's largest obturation system is still carrier-based obturation. But you'll notice that even Ruddle, Shenamblo, who was one of the people behind ProTaper Next, they're all, and certainly Buchanan, who for years has sort of been the these have sort of been the ruling gurus of endodontics. They're approaching carrier-based obturation now as well. You see a lot of that in Italy.
Give name brands. Are you talking about Thermofill, Softcore?
Well, Thermofill, in its early days, it carried a bit of a. There was a lot of bad. I don't know that the material was bad. I think it was, again, there was the implications of the material. Maybe the early iterations of it weren't great, but certainly with Guttacore and what they've done recently, from a standpoint of what Dentsply has come up with, I think with what you're seeing with Real World Endo, where they're using bioceramics and single core gutta percha cones so that it can be retreated, I think Thermofill, as it was in the early days, wasn't the greatest thing going. But I think that, like anything else, the iterations that have gone on over the course of decades has now led people who at one time were Schilderian, left, right, and center, to move towards carrier-based obturation.
In my humble opinion, I think the reason Thermofill got such a bad name is because of what you were saying earlier. Dentists just thought obturation was the key, and they would file these things out to a 25 or 30 and shove a Thermofill in there, and they didn't realize that you open up the canal and then cleaning and shaping with irrigants and ultrasonics, and it was just they were basically doing radiographic X-ray. If it looked good on the X-ray, it was done.
Exactly. And the interesting part about it, though, is that if you look at the early Schilder work, his envelope of motion stuff, what's happening in endodontics now, for example, is the major controversy is, are you doing harm to teeth by persisting with this conventional endodontic look approach, the Schilderian so-called look, the need to have volume in order to develop rheologic flow so that you could pop lateral canals, et cetera, et cetera. The push now, certainly, we see it, I think we've seen it with people, Mark Paulson, for example, the New Jersey Endo Association, has brought in some phenomenal people. Michael Trudeau comes to mind. There are others. And the push basically is that you're going back towards a more minimalistic approach. And I think, again, if you look at what guys like Branson and Kademi and Clark are advocating, the whole tapered concept is disappearing. I think there's going to be a need to renew obturation. It may be carrier-based. I don't know, but I certainly think what you're going to see is smaller canal preparations, more tapered, almost as if they were designed for silver cones, less tapered rather, as if they were designed for silver cones. But I think you're going to see a massive push to new irrigation devices. That's Keishan, photoactivated disinfection, PIPs, but again, that's laser-based. We'll see. Certainly has done some work. Endovac that Schofel came up with has some pretty strong implications. It's a bit cumbersome, but I think you're going to see a redirection. For example, Bruder, the fellow who I believe is at SUNY, or Stony Brook, I guess, in New York, he and Ove Peters came up with True Shape, and that's the new Dentsply file. That file is going to change the need to how you obturate because it shapes differently. Martin Trope's XP Endo finisher is also going to change the way things are shaping. It's not Martin Trope's, it's FKG, but he, DeBillion, and all the others that are advocates for it in terms of its efficacy for true debridement, I think you're going to see some need to truly rethink how we're obturating root canals. And I think that's why, personally, I think bioceramic is going to be important because it's hydrophilic and its capacity to flow and be controlled is impressive. And having met with Dennis Brave and Alan Alanassa, just the point to be made, if you want to think about it, what we've done for all these years, even with Schilderian obturation, the so-called quote-unquote three-dimensional obturation, you can't obturate in 2 dimensions. That was such a specious concept. I mean, how can you obturate in 2 dimensions? You can obturate in 3 dimensions, but you can obturate badly in 3 dimensions. What they've done, though, now is that because of the bioceramics and the sort of the ability to get those things to flow into nooks and crannies that are now being removed by better dissolution methodology, I think you're going to see a shift. And it won't be that the so-called carrier-based is the essence of it. I think sealers will be improved, but the whole goal was to minimize the sealer, right? That was the key. You wanted to massive quantities of gutta percha to minimize the amount of sealer. But it's interesting because now with bioceramic as the filling material, it may prove to be the more efficacious means of closing down a root canal system. And I think that they're making a real concerted effort. I have a lot of respect for the real world endo guys in terms of how they're approaching this. They're not coming at this on a marketing juggernaut. They are only bringing in people who are really committed to it, who are true KOLs, serious advocates, and doing a ton of research as well. And by the same token, just to sort of back that up, one of the things we don't have in America, which offends me no end, is the SAF file system from Svi Metzger. It's the one that looks like a cardiac stent. And worldwide, it's gaining tremendous traction. Germany, India, but it was kind of dispensed with in North America simply because the original motor didn't work. So I think overall, you're going to start to see that the ability to shape minimalistically, but ensure that you've eliminated the labyrinthine irregularities, your ability to irrigate supremely in ways that we were never able to do. You're going to see, in my opinion, the bioceramics or materials like bioceramic are going to be the ultimate obturation methodology. It will not be gutta percha.
And do you have name brands today for that bioceramic?
It's the Brasler root. What's it called? Root. The sequence that comes along with sequence. It's my brain just stopped working.
But it's Brasler.
It's Brasler's material. They have the sealer. They have the putty. They even at one point, I think they realized that you can't take in. You've got 7,500 endodontists in North America, which represents about maybe 10% of the people doing it. And, Schilder has so many advocates that they realized that one of the things you couldn't do with bioceramic was use a vertical compaction technique that involved the application of heat. Well, they even came up with a sealer now that allows for that. That's not the nature of how they want to see this manifest. But they realized that in order to get people to shift their paradigms, that they were going to have to sort of incrementally do it in steps. So it's the, I'm blanking. But it's from Brasler.
Every time I hear Brasler, I always have a 1/10 of a second like, oh, I miss Peter Brasler. He was
a genius. And now you've got guys like Jack Burleson, Caries. I mean, Jack is a super guy, Trope. As I said, I have a lot of respect for the fellows that have come on board. They aren't FKG. There's certainly arm's length. I mean, when you start dealing with the marketing in the United States, that sort of thing. It's not, I have a lot of respect for the FKG company. They develop fabulous instruments, and they do a lot of research in their work. It's quite impressive.
Okay, it's my job to try to guess questions from these 7,000 individuals. Dentaltown, no one has to practice alone. You threw out some terms, MTA, bioceramic, biodentin, and I'm sure 1,000 people are saying, okay, what are those three, and what's the difference between those three?
Well, mineral dioxide aggregate was developed initially by Tor Binajad, who I believe is still at Loma Linda. And it was essentially Portland cement that was modified. And through his research and his studies, he found tremendous capacity for this thing to affect sealing and closure, this, that, and the other. They've introduced it, for example, into root canal sealing cements, which is actually ridiculous because the stuff doesn't bond with the sealing materials. The bioceramics, I wish I understood it as well as I should. I use the putty now exclusively for perforations and repairs, endodontic surgery. I've moved away from MTA because I do believe mineral trioxide aggregate in root end seal tends to wash away.
And you buy it from Brasler?
Yes.
Okay.
Yes. I mean, MTA now is, I don't know if the patent's off, but there's MTA Angelus, there's different companies that are providing this worldwide. The endo sequence stuff, the Brasler materials, the sealers and stuff, I think it's exclusive to Brasler at this point, although I may be wrong. I know that there's the initial development of this material, if I've got it right, was interestingly enough in Eastern Europe, in Bulgaria. One of the fellows on Nexus, Valery Stefanov, has always, for years, talked about this material and the fellow who was behind it. But again, I don't know much about the dynamics of the dental industry, but, you have all these patent issues that come to fore, this, that, and the other. Things get shifted around and this, that, and the other. But I do think that's where the future is going to go.
And then what's biodentin?
Biodentin is, I think, septodonts material. And again, it's supposed to be pretty decent, but the septodont has had a history of kind of being a little questionable, if you will, with regard to research and whatnot. But I know some of the fellows like Antonis Cheniotis, who's got one of the webinars up on Dentaltown. A variety of those people are using biodentin, which is similar. It's similar to BC putty, for example, and using it to do much the same thing MTA did. They seem to achieve the same results. Pulp caps, pulpotomies, external resorptive repairs, root end sealing, this kind of thing.
Okay, Ken, when we're talking all this, the 3 parts of root canals, finding the canals, cleaning and shaping, obturating, isn't it still true, though, that the number one cause of a root canal failure is they miss an entire canal, just missed anatomy? Is that still the norm, or or is that not so?
I think there's a lot of missed canals. I think that's a big issue, always has been. I mean, for years and years and years, everybody got all excited. They found the MB2 in the mesiobuccal root of upper molars. Well, they didn't find it. It had been there all along. They just started looking for it a little harder, and whether it was loupes or scopes or whatever, they were always there. We knew about it for 100 years. What's interesting now is if you take a really hard look at the shift in the mindset, is that the lower first molar, I mean, look at the 2 teeth that are most historically done endodontically, upper first molar, lower first molar, in terms of decayed, missing, and filled issues. But they're now looking at the lower first molar, which I guess if you go back to a study by Nair that was not done that long ago, they're starting to find in some cases that there's almost 40% of the mesial root of lower first molars has a middle canal, like MD, ML, MX, call it what you will. But the incidence of multiple canals and bicuspids and, when we used to look at the studies, lower bicuspids having second canals in 30% of cases. The first study that came out, for example, on lower molars, for example, in terms of third canals and mesial roots, said somewhere between 1 to 15%. The latest study says 46%. So, without question, I think the ability to identify the canal system, the access to the canal system is crucial. There's this whole new philosophy about restorative-driven dentistry and minimal access preparation, which concerns the hell out of me because minimalizing access without microscopes or without some type of magnification or some type of ability to work in that context, you're going to miss stuff. You're going to leave stuff behind. I think we need to have a better understanding of which way the pendulum is swinging and ensure that we have eliminated source resource of infective or detritus material within the chamber. Find all these canals. I mean, there's a trick that I've used for years that I was taught by a person I consider to be one of the geniuses in modern endodontics, and that's Marguerite. I sandblast the floor of every chamber I treat. There have been people like...
with what, a Danville microetcher?
Danville microetcher.
Oh, I love that thing. God, that's my hand.
What a great little tool. I mean, they use everything from Caries disclosing agents to plaque disclosing agents to ophthalmic dye. Sachinella Patty, who was a rooter, came up with a study on that. But it's interesting. Margaret always talks about it. You take your Danville microetcher, you sandblast the floor of the chamber, put a drop of alcohol inside, and I don't care what you're wearing or using, the canals that are there jump out at you because you've satinized the floor. And these irregularities, be they fusion lines, be they canals, be they whatever, they literally jump out at you like they're 3D. They're fantastic. Tremendous tool for endodontics as well.
Yeah, I think the Danville microetcher, that's like WD-40 married duct tape. I mean, it's just God, I can't think of many things. Okay, so low hanging.
Don't forget Teflon. Teflon, the unsung hero of literally all restorative and endodontic procedures to ensure that you have isolated plumber's tape, that you have isolated the tooth and ensured that your matrix is not leaking or whatever. Pretty impressive stuff.
So when do you think we're approaching standard of care that a two-dimensional film of a root canal before we do it is not standard, and you need to see a CBCT so you would see all the main anatomy, or is
I,
that?
yeah, I think we're in an era where you're always going to have concerns about radiation exposure, but realistically, the companies are getting better. The degree of exposure by CBCT is being minimized. Machines are coming down in price. I think it's going to be a piece of equipment essential in your office for literally everything. I mean, the whole push in dentistry is the digital workflow. It may be accelerated a little bit because it's like cars. Everybody likes shiny and new. But I do see the day when, it's like a Panorex. Panorex does something, but, what? So now they came up with digital pens, and most of these systems now have, bolt-on part, equipment that includes software that allows you to do it. I suspect that all dentistry will eventually require CBCT usage as a diagnostic gold standard.
What do you think was a greater invention in oral radiology, the CBCT or the genius on the panel who put the R on one side and the L on the other?
Who put the what?
The R on one side, the L on the other.
The R and the L, without question.
I think that every single patient ever saw that R, is that the right side? I thought, man, that's the most genius thing that ever came out on oral radiology.
I sit there with the guy that invented whiteout and Post-it notes.
Okay, so we were looking for misanatomy. We may use a CBCT if we have access to that, et cetera, et cetera. Let's go back to the second thing. They've got the working length. They've used an apex locator, digital X-ray, whatever. Go through your irrigate. Well, first of all, talk about apex locator. Let's solve this problem. A lot of times, dentists are saying the apex locator isn't really matching what I'm seeing on the X-ray. Like the apex locator says I'm at the apex, but on the two-dimensional digital X-ray, it looks like I'm short. Short. What would you say to that, dentist?
Yeah. Well, X-ray, I mean, there's no question. I mean, everybody's done a zillion studies showing that the X-rays are inaccurate depending upon angulation. Apex location is based upon a physiologic phenomenon. It exists. I mean, it's the differential of 6.25 microamps and 40 microohms or whatever it is. Again, I'm getting old. But I think what you've seen over the course of time is that we've gone through all these iterations. I think we're into our fourth generation on apex locators. They're using microprocessors and algorithms. I don't promote product, and I never would. But the ROOTS EX was the gold standard for years and years and years, and then they came up with these much smaller ones, which were more mobile, this, that, and the other. I mean, I'm not an advocate of any company. I don't do that. But I got to tell you, the apex locator that rocks my world today is the ProMark by Dentsply. I mean, if I was committing funds to buying a device today, that's the device I would be purchasing. I don't know who thought it out, but it's very clever. It's like a flip phone, right? So it comes up, you can change it, you can angulate it. It's rechargeable, which means you're not blowing through a million AA batteries. And the other nice thing about it is they're using it's a digital readout, but a digital readout, I like the graphic imagery is fantastic. And I found that its accuracy is unimpeachable. So, yes, you're short based on a radiograph, but unless you're dealing with something that's, really you've pushed the boundaries, like a canal that's just hemorrhaging like crazy, okay, you're going to have a problem. But most of us have learned how to use superoxyl or hydrogen peroxide to negate that from occurring, or even calcium hydroxide will stop aggressive hemorrhagic exudate, that sort of thing. There are obvious areas where you have to be concerned, open apices, whatever. The standard traditional things.
What about Cutrol or irrigating with 1 to 50 epi to stop bleeding?
It'll do it. It'll slow it down. I guess I'm always concerned about using the root canal as a conduit for epi into the body on any level. So I mean, you can still blow it out under pressure.
So what would be your first choice in this canal will stop bleeding?
First of all, if for example, when you pop into a very hemorrhagic tooth, it's the chamber that just blows out at you. And for that, I would use superoxyl. Wipes out the tissue, but I don't like putting superoxyl down the canals because if it leaches out, you got a problem, big time. But I use hydrogen peroxide. I use calcium hydroxide, again, controlled using the Navi tips from Ultradent, controlled. and leaving it in for, I don't know, 5-10 minutes, it'll stop it. It'll stop it. I guess my biggest concern with using, there's a terrible tendency, we're dentists, right? It's like anything else. You've got something in your hand, you're getting counter pressure, you're going to push a bit harder. I wouldn't want to be using 1 in 50,000 into a small canal and run the risk of, blowing it out like a fire hose.
Okay, and I know you're not a pediatric dentist, but you are a legendary endodontist. What about when you're doing a pulpotomy or a pulpectomy? What's your agent of choice? And there is still some rumbling among younger associates who are working with a dentist our age who says, well, he's using formicresol, and that's carcinogenic, and he could be inducing cancer. What would you say to that kid?
No, formicresol and Crescidin and CMCP and all that stuff should be relegated to the museums. I would be using ferric sulfate.
Name brand?
The one I use is the one from Ultradent. What is that one? Viscostat.
Viscostat?
Yeah, and
that's for a pulpectomy?
It's for a pulpotomy in a primary tooth. I mean, there are certainly indications for doing root canal therapy in primary teeth. The one thing I would never use is calcium hydroxide, simply because it's been shown to induce a lot of internal resorptive problems, this, that, and the other. But, I mean, formicresol had its day 30 years ago.
And Crescidin, what was the difference between formicresol?
Crescidin, again,
throw them away.
These things were teratogens. I mean, they just were not. They didn't make a lot of sense, or at least as I recall. I mean,
you said 3 of them. What was the third one? Formicresol, Crescidin.
Formicresol, Crescidin, which is great if you're trying to preserve tree stumps, and CMCP. But I don't think any of those, from a standpoint of bacteriostatic, bactericidal effectiveness, really made a lot of sense. There's still a lot of dispute about 1 visit, 2 visit. I know that in my own, I'm never going to shift away from 2 visit in necrotic cases. Too many chances of Phoenix abscess. I've been a follower of guys like Jose Sequeira in Brazil, and certainly guys, one of the geniuses behind this, and the guy that, you want to talk legendary endodontists. I don't necessarily rank myself in that area at all.
You are absolutely a legendary.
There are legends.
Ken, I've been in 50 countries. Fred Barnett, he's a legend too. And Joe Dovkin, he passed away.
Joe Dovkin, that was tragic. Joe Dovkin was probably one of the finest minds in endodontics.
I know.
Fred Barnett is probably one of the greatest teachers in endodontics. We've got people coming up today. There are guys like that you don't see in America, tragically. Leandro Pereira. I'm working with you now as your global clinical director, and I'm always trying to get these guys to, they've never been in America. Antonis Chaniotis, Leandro Pereira, Roberto Costecu. There are some people in India, Shivani Bhatt. There are some staggeringly brilliant people that just don't come to North America. Jorge Vera in Mexico. It's just, these guys they're teachers, they're professors, they're researchers, they're clinicians. It's just fantastic the way things are shifting, and I'm glad to see that. And Ilkishin, I think, is going to be one of the real superstars of where endo goes in the next few years. And I think it's beginning to show, because you see him, interestingly enough, not in North America everywhere, but around the world. He is starting to gain more traction in North America, which is great, because he's a Toronto guy now, too.
And give some rest in peace words for my buddy Joey D. How would you write that obituary?
There wouldn't have been a Roots without Joe Dovkin. Roots, I was friends with a guy who came up with the software, and sort of that's how that thing got going. I just found that when you work at, we didn't have a whole lot of study groups, and even the groups that we were working with in Toronto weren't doing much. And I wasn't learning at the rate I wanted to learn. So somehow Joe Dovkin and I came together with Barnett and a number of others. Even Gary Carr was on it in the early days. Terry Pancook. Who else in those days? Kademi was on for a while. He then moved over to Dentaltown, did a lot of good work, and what he did, David Clark. But Dovkin was an interesting guy. He was as I recall, he used to write software before he was you guys graduated from the same school, right?
I was in room 915 of Swanson Hall at Creighton University in Omaha, Nebraska, and he was like in room 919. And I swear to God, there was there were 88 guys on the floor, and they would come from 3 floors down because you could not ask the guy a question where off the top of his head he couldn't write a book on it. I mean, he was a freak.
Totally brilliant guy.
Oh, my God.
When he got out and practiced, I guess he practiced in Scottsdale, right, with John Stropko. And those guys came up with what I still use, which is still the coneless obturation system. Joe worked significantly with, I can't remember the fellow's name at Vista Dental, but I mean, I don't know how many patents or how many devices he had to his name, probably well into the 20s. He was always tinkering with something. Just before he died, actually, tragically, he was working on with Mark Balson on, I'm trying to think if I'm saying this right, electrophoretic irrigation device. I don't know if it ever got the prototype, but they certainly had done research on it. They had a Facebook page on it. I think Mark, as part of his legacy, was trying to see if they could ever bring this to market. But this was work that a fellow named Bill Costerton, who unfortunately also passed away, was doing on, it's almost like activated, Jesus. Trying to remember the specifics of it. I'd have to go back and read it again. But Joe was a genius, and he was the leader of the Roots summits that we did. He was always the moderator for years and for years and for years. And then tragically, I mean, he lived a long time. He had a horrible disease that did stem cell, and he lived a long time. I mean,
rest in peace,
huge
Joe.
legacy.
Rest in peace, Joey D.
Yeah.
He was the greatest dentist ever walked out of Creighton, maybe one of the greatest endodontists ever. But I want you to go back to something you said profound that I'm afraid a lot of these kids might miss. I hear so many kids, they'll just flippantly say, yeah, I one-step all my endo. And you're just like, whoa, 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 whoa. I mean, rule number one, if there's a periapical radiolucency, you would just never do that. But when you said necrotic, explain more to these people because they might not know, a cavity gets into the pulp. It looks necrotic, but they think they're down to vital. Talk more about when you can one-step and when you would never one-step.
If there was, again, this is so, the perspective is so skewed, but in my own personal opinion, exudate in the canal at the time of access. Really tissue that obviously is gangrenous. I mean, you don't have to be a histologist. You're not slapping it under a microscope. But certainly tissue that's gangrenous, you can see it just by what you're pulling out. Retreatments where there's been just, various oxides and leakage and this, that, and the other that was permeating the dentin. Obviously, the presence of a periapical, or some sort of periapical or periradicular lesion. We get back to the question of, does calcium hydroxide really work? And so you've got all these guys that are saying, they swear by it, and then there are the guys who swear at it. I still think that there's nothing wrong with one-stepping a case, but I still think that in this day and age, with biofilm, with recognizing what it is that causes biofilm recidivism of treatment outcome success. And the guy who's the genius on that, again, Nestor Kohenka, published one of the best textbooks ever on that recently. I mean, this is the guy you want to talk to if you ever want to talk about him, and Keisha should be the guys leading the charge for how endodontics is going to move forward. I think that's the issue. You have to really look at the tooth in question, its strategic value, the patient's medical state. I mean, you're talking about diabetics. I mean, look at the way we're all living longer today. We're all living longer thanks to live better through drugs. You got to really take a good hard look at the patient themselves. Are they immunocompromised? There's so many factors that you have to weigh into account. I don't think time is the factor or speed is the factor. You have to really have a very long, hard look at the patient's medical state, the condition of the tooth, strategic value, what you pick up in the radiograph, how well you, and again, it's how good's your radiograph? Are you really picking up what you should? I don't see there being a reason to plow ahead. I know it may be a question of time, an issue for patients and whatnot. But if you're going to create a greater percentage of success by delaying it and ensuring that there is a marginal difference in sterility, then do it.
Okay, so let's talk more about while you're cleaning and shaping. A lot of people use all kinds of lubricants or chlorhexidine or stuff to help the file glide. Do you use any of that stuff? What do you think of those things?
Well,
EDTA. What's the most?
ProGlide and all those sort of preliminary stuff are very good because if you're dealing with tissue, a lot of tissue, the value of those is it doesn't allow the tissue to be sort of pounded and impacted apically. A lot of times they get into the canal, they didn't use ProGlide or one of these things, and they're pushing tissue apically, and suddenly they hit this sort of block of tissue that's been impacted, and they go, whoa, blocked canal. Well, if you left sodium hypochlorite soak in there for 10 or 15 minutes, it wouldn't be blocked anymore. The value of chlorhexidine is what I use to swab around the tooth and swab the tissues before I put a clamp on and before I do any treatment. Its value in terms of its use as an irrigant doesn't dissolve organic debris, and it is bactericidal and effective. It leaves residue in combination with sodium hypochlorite, so it should never be used. EDTA, yeah, I agree, but again, I use citric acid, and that was Joe Dovgin's thing. I use citric acid in 20% concentrations, which you can have made in compound pharmacies. I don't use EDTA any longer. But you need it as a chelator to ensure that you're clearing things out. I think the bottom line key to all of this is that, everybody's run the gamut. You heat the sodium hypochlorite up, which is fine because, you heat it up, but by the time you get it into a canal, it's got about 0.008 cc's of volume. It's still only at body temperature. The heating it up doesn't make that much of a difference. I think the key, and I think you'll read it everywhere, the key to using sodium hypochlorite is if you don't do a ton of endo a week, then take your jugs that you're using and toss them unless they're properly stored. You should probably there are chlorine indicators to measure how many parts per million of chlorine are residual in what you're using. I mean, at $4 or $5 a jug, pitch it on a regular basis. I think the need to consistently and endlessly replenish throughout the procedure is the answer to optimizing your irrigation protocol.
So, what's proper storage on bleach? Do you recommend refrigeration?
Well, you don't want to store it in anything that's too hot. I don't leave it in a refrigerator either. But I think it has to be stored in a sort of ambient area that's an ambient room temperature type of situation, not in a closet next to your suction and compressor.
I always cringe living in Phoenix, Arizona, because so many times whenever your supplies come, the back of the truck is like 140 degrees.
Well, exactly.
And all your stuff was
it by that point in time.
Oh my God! Yeah, everything's been preheated in the oven before I get in my office. So citric acid. So to those kids who explain the difference between EDTA and citric acid and why. What is EDTA and why did you change the citric acid?
It's ethylene diamine tetracetic acid. Citric acid is, of course I'm pulling a blank right now, but it does the same thing. Its efficacy, or at least its mechanism of action, is as a chelator.
Explain what a chelator is.
Chelator simply removes the inorganic component of the dentin. In theory, it softens it, and it removes and opens up the tubuli. It's the same reason that you would, ideally you would use it.
So you're basically saying, okay, look, you got to find all the canals, and a CBCT might help, and just spending time looking. We both agree that I cringe when dentists try to save the crown, usually because they made it. So they drill this little bitty pinhole. I always remove the crown.
I got to stop you here for 1 second. There's a caveat on that. The only time that you would ever keep a crown, in my opinion, unless it was part of some massive roundhouse, would be if you were the person who placed the crown in the first place and you knew that before that crown went on, you had done a proper rehabilitative treatment of the tooth that was being prepped in terms of cleaning caries, what you use to rebuild the core, et cetera, et cetera. To me, there's a lunacy involved in the tooth is degenerated, you've got a lesion, you've got a crown on the tooth. The crown didn't go on there because there was nothing wrong with the tooth. And you have to assume that once you get inside the vast majority of these things, you find gaps between the filling and the tooth structure. Dentin that's been decayed, whatever. You can't clean out laterally or collaterally, whatever, or circumferentially. I have a problem with that. I always have. A tooth that is failing, crown. I realize there's cost considerations, this, that, and the other, but we all know that coronal leakage is the worst possible thing for positive treatment outcomes in endodontics. Well, why would you do the endodontics only to have it leak again? And I think that's the tragedy too often, is that we just say, okay, we'll go through the crown, no problem, assuming that everything's going to be copacetic. It's just not right.
I always remove the crown. Even if I made the crown, I know it's all cleaned up and it just died, I still don't. I mean, if I just sold you a new car and then I have to come back and take a chainsaw and cut a hole through the top of it, I mean, to me, it's just more kosher. Just take it. Plus, the root canal is so much easier without the crown on.
Well, that's another consideration. And one of the things that fascinates me is that we've always, historically, full coverage has been the sort of sine qua non, if you will, of endo-restorative. But that is massively changing today. I don't know how much in the United States, but certainly in what we see daily on Nexus, for example, the EMAX inlay-onlays that are being done, the partial coverage, the ability to sort of rebuild the tooth with glass ionomer or componomers or whatever, and then do EMAX onlays or lithium disilicate onlays on top of these things. You're just going to see a day and era where there is not going to be full coverage anymore. And so there's all these changes that are going on right now, I think, are ensuring that dentists are going to wake up to the fact that you don't do an endo and then you restore the tooth. It's endo-restorative. It's been a continuum that should have been the paradigm for treatment from day one. There are a lot of people talk about it, but I don't know that a lot of people live it. But endo-restorative it's like the AAE, the American Association of Endodontics, for years has tried to sort of re-engage with the other specialties. You know, endo sort of ended at the orifice mentally. That was the mindset. That's been wrong forever. And thank God for people like Clark and Kademi and Carr and others, Rick Schwartz, Ron Franzman in the Netherlands, guys like, you've got some guys that are just doing stuff like, what's his name, Bojdar Kofilev in Bulgaria, Imran Kashim in South Africa, Maxim Belograd, who was, I believe, an endodontist to start in Ukraine, now in Czechoslovakia. Guys who are showing you that you can do endo cleanly without, blowing the tooth apart. But even if you're going to do full coverage, the beauty of preparing the tooth in advance of treatment so that you can identify peripheral root morphology and pick up all of the vagaries and nuances that make a difference in terms of canal identification. That's the way to do it, Howard. That's the key. What you're describing is ideal. Prep the tooth, provisionalize it, but do the endo before you place the provisional. At least work within a prepared environment. What these guys are doing with their sort of minimalistic approach is that they are not taking the tooth apart, but they're opening it enough that they can get a full sense of where that root canal system is going. And it's staggering the way things are changing. That's the key. And I think a lot of it is coming to the realization that things like crown lengthening, which seem to be associated with a lot of situations, really doesn't give you the results that you think that it should, surprisingly. And that's why I think you're seeing more of these inlay-onlay, EMAX type of restoration showing up, because those things can be carried down. And there's just tons of guys, especially, again, back to David Clark, who has done phenomenal work with his clear matrices and this sort of thing, about isolation and their ability to find margins that are subgingival without lasering or cutting away tissue.
Kendo, give us some of your being around the block for 34 years. A lot of times younger dentists are having a problem. They see a failed root canal. They're looking at the lady's age. She may be 60 plus or minus, and they're just sitting there saying, she's got limited money. Should I be dumping this into a retreat and redo the root canal that looks kind of fine on the x-ray, just failed, and redo all that crown? Or if I'm going to spend $2,500 retreating a root canal, build-up and crown, should I just be pulling that tooth and placing an implant? So give us some guideline, 30,000 feet above the ground view of when do you just extract the failed root canal and place an implant, or when do you do a retreat? Or retreats passe because of implantology?
No, I don't think so. I think the key right now, it's interestingly enough, retreatment sort of, they occupied a very big part of the armamentarium that was being developed for endodontics. There's a fellow right now who is working with Steve Buchanan, Yoshi Terauchi, Japanese lad, who has come up. Steve just launched dentalcadre.com. It's a website. And they've come up with this amazing retreatment kit that Yoshi invented. But what you're seeing now is there's the swing initially was, yes, you should retreat before you remove. And so when implants came on board and everybody looked at these teeth that were failing, oh, screw this, out it comes, let's go. You know, what do you need a tooth for? Well, that was all fine and dandy, but implants are not panaceas either. You know, it isn't like you take the tooth out, put the fixture, and everything's fine. We've woken up. I mean, periimplantitis, perimucositis is a reality. Implants fail, and when they fail badly. And they fail a lot worse than a tooth that cracks or this, that, or the other. Cost implications are monstrous. And doing implantology today isn't kind of like the hotel room course deal that it once was when it started out, where it was just about, well, let's put the fixture in. People are waking up. It's hard tissue, soft tissue augmentation. You know, you look at what guys like Maurice Salama and Picos and all of these other people are doing worldwide. The whole, there are guys in Russia, guys that we've gotten to post on Dental Town. Samuel Blyan, for example. So I don't think that it's, gee, the root canal's fine, let's take it out and put an implant in. It's not a guarantee. But what's happened is we need to appreciate that not everybody can slip a broken file out of a root canal system or for whatever the cause of the failure is. If it's straightforward and just obviously poorly done, then I think the retreatment is automatic. But if you're looking at things like files that have been broken away, I mean, I would love to say I can pull files out of a tooth left, right, and center, but I don't think my success rate is all that high. I think what you're seeing is that there is a pushback a bit. Everybody said, yeah, we could take these teeth apart, no problem, retreat them, and then restore them. But there is a push now to recognize that endodontic microsurgery, especially if you're taking into account the hard and soft tissue augmentation materials that are currently available pandemically, and so they're throughout the world. If you incorporate that aspect into endodontic surgery, I think you're going to see retreatment. There'll be a pendulum swing between surgery and retreatment that will probably lead to more surgery, but done with much greater care and sophistication. So I don't think you'll be taking out as many teeth. I think that unless you're dealing with blatant fractures or, you know, crown root ratios that are just atrocious, you know, periodontal issues that are perioendo issues, this, that, and the other, taking a tooth out, because it's simple and easier to so-called put in an implant is a very specious statement. I think the key is if you can retreat it safely, you retreat it. You have to evaluate the complexity of the retreatment. Is it something you can do or that you have to refer? Even the endodontist has to view it in the context of, is he going to be able to remove or retreat without doing any further damage that might end up iatrogenically that would lead to fracture? What's the complexity of the tooth? What's its vital position in the arch? This, that, and the other. Is he better off doing retreatment? If he does it by retreatment, did somebody, you know, there was who's the fellow? Bill Nudera just published an article, JOE and Rodrigo Cunha, I believe his name is. He's a Brazilian lad who's at University of Manitoba right now. Just posted a case the other day. You don't have to take the tooth apart to retreat it. If it's a single canal that's failing or a single root that's failing, go back in and treat the single root. It's sort of restricted selective retreatment. It could be done surgically, but, you know, again, when you redo it surgically, you really have to evaluate what's in the canal system. So I think more and more, if the endodontists and the periodontists and the restorative dentists were willing to communicate a little better, we probably see less, less indiscriminate removal, more selective placement of implants, if that's what it comes down to. And I think you're going to see a pretty significant increase in endo microsurgery in the next little while. I think it's going to cut the pendulum will swing back.
So, Ken, you said you would not one-step a necrotic tooth, and you would.
I don't. I just.
Yeah.
And I mean, again,
you wouldn't one-step a retreatment either, would you?
No.
Yeah. So
Absolutely.
So when you've cleaned it, so back to specifics. You have a necrotic tooth. You did a retreatment. On your irrigation, is that just mainly during the filing and cleaning and shaping, or do you fill it up and let it sit there and replenish the soaking of the
My my
sodium
my
hypochlorite?
my irrigation is endless and constant.
But when you're
Throughout.
done, but when you're done cleaning and shaping, do you
Right.
still keep? Do you just let it soak for 5 minutes, 10 minutes, a time period, or keep
To
replenishing
be
it?
honest with you, I use Qmix, which is one of Dentsply's products, particularly their second generation. I've used it. I used to use
What
MT8. Qmix is their,
spell it?
Qmix. I think it's now Q2 Mix. They've got a second generation out right now.
That's your
Uh,
intermediate medication.
no. I leave it soak, and then I dry it out, and then I place calcium hydroxide with ultra dense Navi tips. These
Alternate.
Navi
Okay,
tips
back.
are, yeah, they're great. Dan Fisher. Dan Fisher is the widget king of dentistry. He's a genius. Who could imagine all these little itty bitty things were so
The
important?
first time he showed me Viscostad, he cut his own wrist. I mean, cut his own
He used to
forearm.
bleed himself.
He
That's how when
he
he
cut
started in the
himself.
80s.
That
He used
guy.
to bleed himself. Scary.
I
It's just
love that guy.
brilliant.
He is the most. He might be
He's
one of the
quite
most
unique.
passionate people in dentistry.
Yeah,
And
for sure.
I always love the way whenever you meet him, he's always while he's talking to you, he's punching your shoulder. Whenever you walk
I
away
think
from
he
Dan
has
Fisher, like,
broken more ribs
oh my
among
god.
dentists than any human being alive.
Okay, so then your intermediate medication would have been the Ultradent calcium hydroxide.
I use their UltraCal. Yeah, I do because it's been shown that I think it penetrates up to 400 microns.
Well, I'll tell
Uh,
you what, we are out of time. We're into overtime, and we passed an hour. We're at an hour two.
I can't talk about the World Dental Journal and all that kind of stuff.
I just want to say seriously, you named a lot of dentists from Martin Trope in South Africa. I mean, to Joey D that passed away. You mentioned a lot of people, but in my mind, in my head, the first endodontist legend in my life that had the greatest impact on my career was you, Ken Serota. I have heard that from more people than have heard that from Steve Buchanan because you started Roots. You were like, and now it's Nexus on Facebook. But you were the leader. You were getting the greatest minds. You had the most serious day-to-day impact on more endodontic thinking on planet Earth than anybody I knew from probably 1988 to now. I mean, you just always been the leader of the pack. And you could
That's
name
pretty humbling,
specific
Howard.
guys from specific countries, but cumulatively, they're all were you were leading the herd, dude. And
Well,
you did so
thank you.
much for me and all my friends. And by the way, Joey D, he lived in I lived with him in Swanson, and we both lived in Phoenix. And everybody always said you're the man, and you are the man. And I can't believe I got you to spend hour three. But thank you, Ken Serota, for all that you've
You,
done for
Howard.
Endo, that you've
And
done for
remember,
so
Howard,
many
never
careers.
forget, no dentist should ever learn alone. As
and
Howard, thank you.
and thank you so much, and enjoy the rest of your day.
Well, you too, my friend. Take care of yourself.
Bye bye.